respiratory chapter is one of the most active chapters in IAP Kerala. And only the last week, respiratory chapter in association with IAP Kerala has conducted a workshop on asthma, a physical one at one of our branches at Malanad, which was organized by the Malanad Idiki branch. And as Dr. Vivekanand was telling, there is a lot of academics happening over the internet this year, thanks to all the enthusiastic academicians as well as chapter office bearers of IAP Kerala. And but there won't be any dearth for a slot for the respiratory chapter, because for the pediatrician, the most important diseases are mainly the respiratory diseases. And today we are discussing asthma, which is always known as the bread and butter for the pediatrician. And we have a very eminent faculty, Dr. Vivekanand, Respiratory Chapter Office Bearers, for arranging this meeting. And thanks to our faculty for taking his time for this. All the best and happy day. Thank you.
Thank you, Riyaz sir. Let me welcome our President-elect and IAP Respiratory Chapter Chairperson, Nandu Kumar sir, for address.
Good evening, respected President Dr. Riyaz, today's chief guest and speaker, Dr. Vivekanand, and other dignitaries on this platform. Very happy to invite you all to the online platform, RESPI. I thank Dr. Riyaz for the great support. And as you already know, respiratory system, other respiratory cases are our bread and butter, especially this monsoon season. We are going to see a lot of cases in our OPD and our IP. All this we have to manage all this. To discuss about asthma, rational investigations in pediatric asthma, and solutions, we have an eminent faculty, young faculty from Rainbow Hospital, Chennai, Dr. Vivekanand. Without wasting much time, I wish all the very best for this program. Thank you.
Our Secretary, Dr. Gobi, for your address. Let me look.
Respected respiratory state chairperson and incoming President Nandumar sir, Honorable President Riyaz, Secretary Vivekanand, and today's speaker, Dr. Vivekananda, other seniors and my friends. I'm very happy that now the respiratory chapter has also taken off by starting this monthly pedi clinic, which will be very helpful for us. As Nandumar sir pointed out and Riyaz pointed out that respiratory diseases are our bread and butter. And I also congratulate you for having this topic, the rational investigations. A lot has been talked about asthma and its treatment, but investigations still is a gray area. And I'm sure that Dr. Vivekananda will make us more wiser at the end of this his talk, and I wish the chapter very best. And
okay, thank you, Dr. Gobi. Without wasting time, we can go to our topic. And Dr. Vivekanand, he is the consultant pediatric pulmonologist, bronchoscopist, and sleep specialist at Rainbow Children's Hospital, Chennai. And he is also working in VV's Pediatric Respiratory and Sleep Clinic. He is having a fellowship in pediatric pulmonology and sleep, postdoctoral fellowship in pediatric pulmonology, European diploma in pediatric respiratory medicine, and Indian diploma in pediatric critical care medicine. His areas of interest are pediatric bronchology, pediatric interventional pulmonology, and pediatric sleep. So over to you, Dr. Vivekanand, for your talk.
Okay, a humble request to everyone to keep the mics muted all through the session. Thank you.
Thank you very much.
You can share your screen.
Right, yeah. Able to see my slides, sir?
Yes.
Yes, sir. At the outset, I would like to thank IAP Kerala Respiratory Chapter for including me in this program. And I'd like to thank Dr. Riya sir, Dr. Vivekanand sir, and Dr. Nandakumar sir, and my close friend Dr. Jijo for giving me this opportunity. So the topic given to me, what I'll be discussing briefly over the next 30 to 40 minutes is we all have a confusion of should we do investigations? How much should we do? How far should we go? And I would like to, I hope that at the end of this talk, I would be able to give you some key 10 points which will be very useful for office practice. So without wasting much time, so rational investigations in pediatric asthma. Now, why this topic is, my scheme of presentation will be, I'm going to go through some basic introduction on asthma. I will briefly discuss about peak expiratory flow rate. I'll tell you why I'm discussing this. I'll discuss about spirometry, the gold standard. I'll also briefly discuss about impulse oscillometry, exhaled nitric oxide test, and some other newer, rarer, and commonest investigations which are evolving and which are already being practiced in and around the country. What I will not be covering in this talk will be, I will not be covering the investigations which are used to rule out mimics. For example, bronchoscopy, CT scan, and other things, which is beyond the purview of this topic. So this is my scheme of presentation. Now, the current GINA 2025, there has been an update recently which has come up, mentions that we need to take a clinical history is always mandatory. Once we get clinical history, we need to test or confirm a diagnosis of asthma. We need to treat, prove whether our treatment is applicable and has worked well, and we need to follow up the check. So this is the GINA update on 2025. Now, it is always prudent to follow the clinical pattern. Right from our undergraduate and postgraduate days, clinical pattern recognition is mandatory in any disease with particular emphasis on asthma, which was previously always a clinical diagnosis. But currently, in our era, we need to show evidence of variable expiratory flow limitation. Once we show evidence of variable expiratory flow limitation, we need to show what is known as bronchodilator responsiveness. Previously, we were calling this terminology as bronchodilator reversibility. Currently, GINA has changed it to bronchodilator responsiveness. Sometimes one test or more than one test may be needed to arrive at a conclusion of a diagnosis of asthma. So asthma is not merely a clinical diagnosis in our current era. Though clinical diagnosis is important, we need subjectivity plus objectivity to arrive at a conclusion. Now, what is the clinical pattern recognition? So the left side of my screen here is what is the typical pattern. So we know that we need to have a history of recurrent wheeze, shortness of breath, cough, or chest tightness. Symptoms are worse at night or in the early morning, particularly between 12 to 4 a.m. in view of the circadian rhythm of steroids. Symptoms vary over time and intensity, and it is always triggered by viral infections, exercise, allergens, fluctuations in humidity, weather, emotion, activity, environmental pollution, tobacco smoke, or strong smells. What is not asthma is chronic sputum production is not asthma. Shortness of breath with dizziness or lightheadedness or paresthesia is not asthma. Isolated chest pain is not asthma. And exercise-induced breathlessness with a noisy inspiratory breathing is not asthma. So these are all asthma mimics. This is all pattern of asthma on the left side. Now, I'll discuss about 8 to 9 scenarios. The first scenario is a 9-year-old boy who was presented with recurrent cough and breathlessness. Nocturnal symptoms are present for the last 3 to 4 months. He has been clinically diagnosed to have asthma. The child is from a rural background. So the physician does not have a spirometry. The parents also cannot afford a peak flow meter, a pulmonary function test. So what can we do? We are not able to get a spirometry. Parents are also not affordable for a spirometry. When in a current era will cost around like 800 to 1,000 rupees. How can we add objectivity to prove the diagnosis for this boy from a rural background? So we have an option. Yes, it's PFR, known as peak expiratory flow meter, as it is seen in this device. we know that it is definitely less reliable than spirometry, but it is better than none. When we don't have anything, use this. You have to use the same meter every time. We have to be cautious about this. We have to take the highest of 3 readings, morning time and night time, and we should document a daily diurnal variability of more than 13%. And once we prove this, we can do a bronchodilator reversibility. We give 2 puffs of salbutamol, and when we do the peak expiratory flow, we see a 15% increase. And in case of an excess-induced symptoms, we can show a fall in more than 15 to 20%. So this is peak expiratory flow meter. How will you calculate is days highest minus days lowest divided by the mean of the days highest and lowest into 100 will give us what is known as the average of each day's value is calculated over a period of 2 weeks. And from this, we are also having online calculators which is available to help us to know the diurnal variability at the highest of 3 readings, which need to be done BD. Now, so if you don't have anything, we can still rely on peak expiratory flow meter. So what if this boy presents in a city-based practice? So a pediatrician comes across a 10-year-old boy who has come to the clinic with multiple recurrent exacerbations. Parents ask us, they're probably an IT couple, they ask us how to control, how should you anticipate an exacerbation? They are worried their child might end up in an exacerbation every time, leading to an admission, sometimes an ICU admission. How can we help this child? This is scenario 2. So they're from a background where they can afford a spirometry, but their concern is not to prove the diagnosis, how to anticipate an exacerbation. Now, the same tool here, which we discussed in the previous slide, peak expiratory flow meter, is going to be of utmost use. It is, I would say, it is underutilized in pediatric practice. I hope let us all start using this very important, simple, non-expensive tool. So what we do is we give this peak expiratory flow meter to the parent with the chart and ask them to note down in this diary over a period of 2 to 3 weeks, and we will know the baseline of this child. When the child starts using, we'll know what is the baseline of this child, whether it's 200, 100. So we did this for this child, and we came to know that this 10-year-old boy had a peak expiratory flow rate baseline of around 280 to 300. Now, what we did is, if you go back to the previous slide, we know that the parents' concern was what should we do when he is unwell. So how to anticipate? So we give them this asthma action plan known as AAP. There is nothing but we have 3 zones: green zone, yellow zone, and red zone. Green zone is nothing but if the child is doing well, this you will remember this child's peak flow reading baseline is 300. So 80% of more, that is 250 above, and if the child has no symptoms, we need not do anything. But 80% and above of the peak flow meter, if the child has mild symptoms, you just ask them to use salbutamol 2 puff 4 hours once for 3 to 5 days till his symptoms resolve. What if this child has 50 to 80% of his baseline with symptoms of cough, wheeze, or tightness of breath? We will ask them to take 4 puffs of salbutamol 4 hours once for the next 3 to 5 days and see whether symptoms improve or deteriorate. And we'll ask them to monitor the peak flow meter more carefully. Now, what happens if this child has a peak flow reading less than 50%? We know that this child needs to be in our emergency department within 1 hour. So within this 1 hour, what we do, we give the reliever puff, 4 to 6 puffs, 20-minute interval for 3 times, and ask them to go to the nearest possible emergency room or to our clinic to reassess this child. So always remember, if the child is on our preventer medications, they always need to continue the preventers. This is only for the relief medications. So this is going to help us to anticipate an exacerbation and get them to an emergency room. Sometimes it will prevent admissions, sometimes it will prevent ICU stays or HDU stays. So this simple tool is inexpensive and it is extremely valuable. So this is with regards to the utility of peak expiratory flow meter in our current era. Moving on to the third scenario. This is an 8-year-old girl who had come to the clinic with recurrent chest tightness in the night time. It was going on for quite some time. Frequent symptoms, they had come with a report of an elevated exhaled nitric oxide, which was 80 parts per billion. Clinical asthma, yes. Elevated eosinophils in the airway, we'll come to this later. Parents are resistant for ICS. What can we do next? So these parents don't want to give ICS. So what we need to do is, this child is 8-year-old girl, definitely they would be able to use a spacer with a without a mask. So what we need to do is, we need to do a spirometry, which is indicated for this child. In the current era, we need to prove a diagnosis with spirometry. Before I go to spirometry, I will introduce some new concepts of spirometry with regards to the Z-score. Just like we have the Z-scores for the growth charts and other things, we are also having Z-scores for spirometry. It is very simple. We calculate the 5th centile and the 95th centile. Any value which is more than less than minus 1.64 is normal. Minus 1.64 to minus 2.5 is mild obstruction. Minus 2.5 to minus 4 is moderate obstruction. And anything more than minus 4 is severe obstruction. So when we look at the ratio, we see if it is more than the 5th centile. If it is more than the 5th centile, then that's okay. But if the ratio is less than the 5th centile, then we look at the FEC. And if the FEC is also less than the 5th centile, we confirm it as obstruction. Now, putting this into clinical practice, now what is Z-score? To be exact, there is nothing but a Z-score tells you how far a measured spirometry value deviates from the percentage predicted value, which may be based on age, height, ethnicity, and sex in standard deviation units. It is adjusted for body weight, height, sex, and ethnicity. It avoids overdiagnosis in small or young children. It provides a statistical comparison rather than an absolute value. We all know that previously we were using percentage predicted value. 80%, 70%, 75% is what we are using. But currently we have moved on to Z-scores. Nothing but we have lower limit of this is 5% of population, less than 5% of population. This is more than 5% of population. 90% of population fall between minus 1.64 to plus 1.64. That is minus 2 to plus 2 standard deviation, which is going to be between the lower limit of normal and upper limit of normal. So anyone who falls in this range between these values is normal. They have low values if they fall less than this. They have high values if they fall more than this. This is simple Z-score. Now we will see this with a clinical scenario of this child. What we did a spirometry for this child. This child has blown for 5 seconds, has a good plateau. This is the flow volume loop. We know that this child has a mild scooping, which is suggestive of airway obstruction. Now, what are we going to do next? Now, we're going to interpret the values. So, we know that we see the ratio. The ratio is more than minus 1.64. You look at here, it is less than the lower limit of normal. So, the ratio is the less than lower limit of normal. Now, let's look at FEC. You see that the FEC is less than minus 1.64. So, it is more than the 5th centile. So, this confirms obstruction. You have a low FEC, or you have a low ratio, you have a normal FEC, and you have a low FEV1. So, this confirms obstruction. Now, what should you do next? Now, we have confirmed obstruction, but we should know whether this obstruction is reversible. So we should do what is known as a bronchodilator responsiveness test. We should give 2 puffs of salbutamol and repeat that spirometry after 15 minutes. This is to confirm the variable expiratory airflow limitation. Bronchodilator responsiveness, otherwise known as PDR. You measure change 15 minutes after a bigger child or adult, you use 400 microgram of salbutamol, 2 puffs. In a smaller child, you use 200 microgram, that is 2 puffs. Now, we see if there is increase in baseline of FEV1 of 12% or more. And we see whether after 4 weeks of inhaled corticosteroid therapy, the FEV1 has increased more than 12% of the baseline. So this is what is known as bronchodilator responsiveness. So we did this in this child. The green one is the post bronchodilator, and we see that definitely there is a very good improvement. The scooping has gone now completely. And when we look at the value, you see that previously the FEV1 was 74, now it is 95, it is more than 12%. The Z-score, if you see carefully here, the Z-score which was less than the lower limit of normal, after bronchodilator, you see everything, particularly the FEV1 has come to normal. This is known as bronchodilator PDR positivity after bronchodilation. Now, very important consideration I would like to say is how much sometimes you may have children of SABA or on LABA therapies. So if the child is on salbutamol, you have to withhold salbutamol for at least 4 or more hours. In personal practice, I withhold for 6 hours. Formoterol or salbutamol, that is LABA, should be withheld for 24 hours. Ultra long-acting beta agonists, we usually don't use it in pediatric age group. Adults use it, we usually withhold for 36 hours. The common prototype drug is called Vilantrol. Triotropium or glycopyrenium, also known as LAMAs, should be withheld for 48 hours. So remember, when you do a spirometry, you withhold this with this time frame. 4 hours, 24 hours, 36 hours, and 48 hours, if you want to simply remember in this box slide. So this is one important find. So the utility of in our current era, spirometry is very, very simple tool, not much expensive. It can be easily purchased. We have desktop spirometries available now and always prove diagnosis in a child above 6 to 7 years of age with spirometry and always prove bronchodilator responsiveness. It will be helpful for you to follow up. It will be easy for the parents to understand. Now, this is scenario 4. What else can we do? So we have seen peak expiratory flow, its utility. We have gone into spirometry now. Now, what else can we do? This is a 12-year-old boy who is an athlete. He has frequent symptoms of cough and breathlessness, but it occurs only after 10 minutes after football play. We know that it's clinical suspicion of exercise-induced asthma or exercise-induced bronchospasm. What can we do next? How can we prove the same? So this was the question which the parents asked. The boy is wanting to compete at district level for athletics. So this is known as exercise challenge. If we have a treadmill or a cycle, what we can do is we can ask him to exercise on the treadmill. We can ask him to come in his sports shoes, sports attire, use the sports shoes, use the treadmill for 6 to 8 minutes. What we aim to do in this test is nothing but we aim to reach 80% of maximum heart rate. So how do you calculate maximum heart rate? 220 minus age in years. This is how we calculate maximum heart rate. And we increase over first minute and then maintain the speed. The treadmill speed is around 5 to 7 kilometers per hour. And we keep the slope at around 10%. The incline which we usually do in the treadmill. We do a spirometry at baseline. If your baseline itself is low, please don't do an exercise challenge because we are going to cause bronchial provocation and this child might have a wheeze attack. So if your baseline is low, we need not do anything. But if your baseline is normal, you do a spirometry at 5 minutes, 10 minutes and later to see if there is a fall in your FEV1. So positive exercise challenge is nothing but if you have a normal spirometry and after exercise, if the FEV1 falls by 12% or more, then it is known as a positive exercise-induced challenge test or positive for exercise-induced bronchospasm. This is how it is routinely done. We don't have a treadmill, but we do a similar principle by using a cycle ergometer.
Dr. Vivekanand, can you speak louder?
Yeah, yes, sir. You able to hear me now, sir?
Yeah.
Yeah, yes, sir. So,
Vivek, your volume is slightly low.
Volume is slightly low, sir. 1 second, sir.
So the one question
now?
anyway, we have broken the speech. When do we do the post-bronchodilator in this exercise-induced bronchoconstriction? Whenever you get a lower level, because you're doing at 5, baseline 5 and 10. So the response do we see only when there is a drop in the FEV1? Or at what point will we do a positive response test?
A positive response is if our baseline itself is normal, then we wouldn't go to this exercise challenge test. But if our baseline is low, if our baseline is low, for example, if our FEV1 in the baseline itself is 60%, then we wouldn't provocate him more. We know that our diagnosis is established. What we'll do is we'll give a bronchodilator and see for reversibility in the child. But if our baseline is 90, or the Z-score is normal. What we do is you do a baseline Spiro, prove that it is normal. You repeat a Spiro 15 minutes after exercise and do it at 5 minutes post exercise, 10 minutes, and then see, you calculate the pre minus post and divide it by a formula and see whether the post exercise which is done, there is a fall in FEV1 by 12% or more. This is how it is.
Okay, thank you.
Yeah. Is my voice clear now?
It's slightly low. Your total volume is slightly low.
No, 1 second. I'll just.
Is it
Slightly better.
slightly better?
One of the questions which has come is, can we use PFR to diagnose EIB, since we are in the same topic?
Yes, sir. We can definitely use PFR to diagnose EAB. What we do is, if you don't have a spirometry or we cannot do an exercise challenges, after exercise we see whether there is a 15% fall. You see a 15% fall in the peak flow meter values, basal values. So definitely we can use it for exercise challenge. Shall we proceed?
Sure.
Yeah. So in this scenario, so what we saw here is the baseline FEV1 was 106. So post exercise challenge, there was a fall in FEV1 to 89. So it is definitely 12% or above. So this is a post exercise challenge. One caveat which I would like to mention here is, we always look at FEV1 fall by 12%. We always also look at the fall in the ratio as well. Probably the patient has not done as well. Then the FEV1, the ratio will not alter. But if it's a true test, if the patient's efforts has been done well, then not only the FEV1 will fall, but the ratio also will fall, as you see here, 82 to 76. There is no specific percentage fall in the ratio, but it should fall. That is the one caveat which we need to know. And if what you should do next is, when we see this, what we usually do is, we again look for bronchodilator responsiveness. We give puffs or 2 puffs for this child, and after 15 minutes, we see whether there is an increase in FEV1 by 10 to 12%. So that is, we'll complete the exercise challenge test for this child. So now moving on to the next scenario. This is the 4-year-old boy. The main issue for this boy was persistent nocturnal cough, recurrent seasonal episodes with frequent episodes of exacerbation. He was a preschool child who is not a candidate for spirometry. So what can we do next? Again, parents were resistant for inhaled corticosteroids, though he had recurrent symptoms. So this is the tool which has been getting more and more importance every day. Some are predicting this is going to be the future of lung function test. So this is what is known as impulse oscillometry. Now, what is GINA quote in 2025? GINA quotes that we can use it from 3 years onwards. It's a very good non-invasive test. Tidal breathing is used. We don't need to use the forced expiratory maneuver. There are very important caution is that we need to use device-specific references. There are 3-4 machines in the market, so we need to use device-specific references. Bronchodilator response, and we look for a fall in resistance by 30%. It's non-invasive and it's effort dependent. It is easier to do. Gina mentions 3 years onwards, but practically 4 years to 6 years is the age with which we usually do. Now, what is this? I would take a simple analogy of radio frequency waves. That is, simply to explain this test is nothing but we impose sound waves different frequencies on the normal tidal breathing of the child. So the child has a normal tidal breathing. We ask them to close their cheeks by the parent. We impose sound waves from a loudspeaker. Air has a good reflectivity to sound. So the sound waves get superimposed on the child's tidal breathing and it's reflected back and we interpret it as graphs. We use different frequency sound waves. Sound waves at 10 hertz, sound waves at 20 hertz. I will take an example of radio frequency. We all know that what is AM radio station, which we hear from Delhi. We know what is FM, which we all have local channels, Radio Mirchi, all those things which you have for independent states. AM amplitude modulation is nothing but
participation ആണ് നമ്മൾ പ്രതീക്ഷിക്കുന്നത്. അതുകൊണ്ട് നിങ്ങളുടെ എല്ലാവരുടെയും സംഘടന അടുത്ത പ്രാവശ്യം ഉണ്ടാക്കണം. മറ്റൊരു കാര്യം പറയാം.
So amplitude is nothing but AM radio stations travel longer distances. So you are able to hear the Delhi stations, AM station in Chennai or Kerala. But with regards to frequency modulation, they have larger frequencies, 10 hertz, 20 hertz. So we know that larger frequencies travel shorter distances. That's why we have individual radio stations for FM. Kerala has their own Radio Mirchi, Bangalore has their own Radio Mirchi, and we have our own Radio Mirchi. This simple analogy is used here. Travel all down to the distal airways. It's the entire total airway resistance it measures. R20 is nothing but it measures only the central airways. And this R5 minus R20, this difference, delta, is going to give us the estimate of the small airways disease. Now, there are reference values depending to the machine. For example, this machine, we follow Z-scores. We see if the R5 minus R20 is more than the upper limit of normal. This is exactly the reverse of what we see in spirometry. In spirometry, we see the narrowing and the bronchospasm restriction. But in impulse oscillometry, we see how difficult it is for the sound waves to go. We calculate the resistance. So we see how high the resistance is. We see here, R5 is the total resistance. So it is well above the cutoff of the Z-score. It is very high. So the total airway resistance is very high. And this is how it appears on the graph. This is the resistance curve. This is the reactance curve. And then next we see is the R5 minus R20. We also see that the R5 minus R20 is well above the cutoff. So we know that this is pure small airway obstruction. This area under this curve is known as AX. So this reactance also increases whenever there is increased resistance. And you see here, AX is also very high. This area under this curve will also increase tremendously. And this confirms small airway obstruction. So what will you do next? We have confirmed small airway obstruction with impulse oscillometry. Next is nothing but what we do is we give bronchodilator and see whether however high the resistance is that fall. So bronchodilator responsiveness is you should have at least the 30 to 40% fall in R5 or 60% fall in AX. One caveat is that this also depends on what machine we use. There is some common machine which we know as Antlia. Antlia mentions that if it's 20% fall, it's enough, and 40% fall is enough in R5 and AX respectively. So this is impulse oscillometry. But take home from this will be always compared with device-specific normative data. Now, sixth scenario. So this is a 7-year-old child who has a proven asthma by spirometry. He is having very frequent exacerbations. Parents question the role of ICS. They are asking, you are treating my child, you are proven with the spirometry, there is no improvement. What else can we do? What else investigations can we do? So now we come to exhaled nitric oxide, also known as fraction of exhaled nitric oxide, also known as FeNO. Now, what is this FeNO? What does it do? It's a very important tool, a bit expensive. A lot of centers do have it. When can we use it? It helps us to diagnose, can help to diagnose type asthma, type 2 asthma, eosinophilic asthma, otherwise known as risk assessment, as well as for follow-up. It's a good tool. Exhaled nitric oxide levels are always measured in parts per billion. Now, how it is useful in diagnosis? Current GINA also mentions that in children who have a value of more than 35 parts per billion, It is very characteristic of eosinophilic inflammation. It can be used as a diagnostic tool. The tool is response to inhaled corticosteroid therapy. It usually falls with inhaled corticosteroid therapy to less than 35. It should be less than 25. And it is used for predicting an exacerbation also. Prognostic values, when a child is on inhaled corticosteroid therapy, if the child still has a higher FeNO, it might indicate poor asthma control. It might mandate that it might indicate a risk of exacerbation, and it might also indicate a lower lung function. So we also need to be aware of some confounders of higher FeNO. Male gender, it's a very broad term. Old age, atopy, nitrate-rich fruits, viruses, and certain diseases can cause higher FeNO. One caveat to remember is if someone is exposed to environmental tobacco smoke, FeNO is very low. So that is one also caveat which we need to remember. Now, what is this FeNO? FeNO is nothing but you have airway inflammation in allergic eosinophilic asthma. Your airway epithelial cells is going to induce nitric oxide synthetase. Nitric oxide is produced in the airway epithelium and it is carried in the exhaled breath. So this exhaled nitric oxide in the exhaled breath with a sustained exhalation of around 3 to 6 seconds. And we clinically interpret it with an analyzer. This is what it does. Eosinophilic inflammation type 2, never use in isolation. You always do, if you have FeNO and spirometry, if you have both tools with you, you always do FeNO first and you do spirometry next. Use as an adjunct or when Spiro is normal or when Spiro is not available. Gina mentions Spiro available. See, usually if you have Spiro, we may have this or we may not have. We will not have a situation when we have a Spiro, we have a FeNO and we don't have a Spiro because FeNO is obviously it's more expensive. So another thing is whenever someone is not able to do a Spiro, you can do iOS or you can also do a FeNO to see for eosinophilic inflammation. Now, how to recently diagnosed FeNO? If it is less than 20 parts per billion, unlikely is consider a DD. Think of a child as a whole. See the symptoms, see the FeNO, see the spirometry, and see if for monitoring, you see if adequate ICS dose, good adherence, and whether you need to taper. If it is 20 to 25, just follow up the child. You see whether technique, allergen avoidance, adherence are all adequate here, and whether good dosage, adherence, and we see whether there is any monitoring and change in symptoms. Our Indian child had 60 parts per billion. So the questions were, what parents were concerned about the value of ICS. You continue to treat with ICS, but for this child, you see if it is, since it is more than 35, see for allergen exposure, adherence, whether your technique, kit, canister, everything is good. Check for steroid resistance or risk of exacerbation. See if there is poor adherence, inhaler technique, and do not taper the medications for this child definitely, because you need to take into consideration all this. And a very important note on FeNO. FeNO reflects type 2 inflammation, T2 high, non-eosinophilic asthma or polygranulocytic asthma, also known as TH2 low phenotypes, can have a normal FeNO or a low FeNO. But still, patient can demonstrate clinical asthma with variable expiratory flow limitation. So, allergic eosinophilic asthma, high FeNO, non-allergic asthma or obesity-related asthma can have a low or normal FeNO. Asthma is still possible. ICS-treated asthma can have a normal FeNO. But all low FeNO does not exclude asthma. This is some of the take-home message from this important slide. Moving on to our last 3 slides in our presentation. So this is a 7-year-old boy. Chief complaint was persistent dry cough for the past 3 months. Child has a persistent dry cough at night, early morning, around 4 a.m. Cough worsens with physical activity like football. No associated fever, nasal disease or wheezing. They are given multiple courses of antibiotics, cough syrups with no response. No history of wheezing or asthma in the father or the parents. So this is what is known as cough, previously known as cough equivalent or cough variant asthma. Gina prefers to call it cough-predominant asthma. There are a lot of controversies. There wasn't a term like people were using this term. They said this term exists no more. But currently, Gina has come back with use this term called as cough-predominant asthma. I know all of us routinely say this in office practice. Persistent cough is the only or predominant symptom. Spirometry is usually normal. Diagnosis may require bronchial provocation testing. some progress to classic asthma with wheeze and bronchodilator responsiveness, and often associated with sputum eosinophilia or elevated FeNO. The close differential diagnosis is eosinophilic bronchitis, though the treatment doesn't matter. Cough is present in both, eosinophils are present in both. Spirometry is almost always normal in eosinophilic bronchitis, but may show reversibility in cough-predominant asthma. Airway responsiveness, airway hyperresponsiveness is present. Eosinophilic bronchitis, airway hyperresponsiveness is usually absent. This is the very important take-home on cough-predominant asthma versus eosinophilic bronchitis. Moving on to scenario number 8. This is the 10-year-old boy. He was brought by his parents. He was diagnosed to have persistent asthma since age 4, spirometry proven. He is unable to be weaned off inhaled corticosteroids, even short term. So almost 6 years he is on ICS. Parents request, what else can be done? You have termed the term asthma. Is this asthma? Why do you call it asthma? Control versus cure. What can we do for this child? Now, obviously, we proceeded to do a skin prick test and found that he was sensitized to house dust mite species. Now, very important to note, all children considering asthma as a diagnosis beyond 3-4 years of age, we calculate the predictive index, modified predictive index in any child above 3-4 years of age or in an older child who has more than 4 wheezing episodes per year, with at least 1 episode is confirmed by the physician. We all know that we need to have either 1 major criteria or 2 minor criteria. The major criteria is nothing but parental asthma, physician diagnosed eczema in the child, sensitization to at least 1 allergen, either by an SPT or specific IgE by the immunocap method. Minor criteria is sensitization to food allergens, mainly milk, peanut, or egg. Peripheral eosinophilia more than 4%. Child should have wheezing apart from URL. So, positive API helps in predicting developing of persistent asthma. Negative, low risk, many outgrow symptoms by 6-7 years of age when the airway caliber becomes. Clinical use helps decide on early interventions like steroids, inhaled corticosteroids, predominantly aids and parental counseling. I know how difficult it is to counsel a child with asthma and particularly the parents about future asthma risk. Now, allergy testing, what does GINA 25 say? Increases asthma probability. Atopy increases the likelihood of allergic asthma, especially when respiratory symptoms are present. Not specific for asthma, atopy is not diagnostic of asthma, and not all asthma phenotypes are associated with atopy. Example, non-allergic asthma or quasi-granulocytic asthma. This is the take-home on allergy testing. Now, what are the allergy testings? It detects sensitization. Like we all know, it is not something new to this audience. Atopy is a genetic state. Sensitization is an immunological state, and allergy is a clinical state. And we all know sensitization does not equate to allergy. So, SPT is if immunotherapy is indicated, or if you want to calculate the predictive index, or the child has recurrent persistent symptoms, it measures the bound IgE in the mast cells. Specific IgE by the immunocap method is used when you don't have facilities for SPT, when you have a recent anaphylaxis, when you have extensive eczema, which is where we are not able to have a good skin barrier to do the test, and caveat is only detects free IgE. Therefore, if a patient has an atopic state with a total high IgE values, it might have a falsely elevated values. So, no, there is no role for total IgE levels in diagnosis of asthma, except for when you are considering refractory asthma, when you want to rule out ABPA, bronchopulmonary aspergillosis, or when you are considering biological therapy for a child with refractory advanced asthma in an older adolescent child. So sensitization plus symptoms equates to allergy. It is essential to do all these tests or a combination of these tests depending on what you have when considering immunotherapy. Obviously, it goes without saying, and to have a proven diagnosis of atopic asthma. Now, this is scenario number 9. This is the first year newly joined postgraduate. He is asking us the role of peripheral eosinophilia in asthma. Should we do, when to do, should we do total IgE levels? I think we have answered the question on when to do total IgE levels. So this is known as PEC. Blood eosinophil count or peripheral eosinophilia can support a diagnosis of type 2 asthma. Low levels do not exclude asthma. We have to be aware in our country where parasitic infections are very common, like tropical pulmonary eosinophilia, low flow syndrome. We should be aware of non-asthma conditions like allergic rhinitis, atopic dermatitis, chronic rhinosinusitis with nasal polyp, Church-Strauss disease or eosinophilic granulomatosis and polyangiitis, and hypereosinophilic syndrome, which may be idiopathic or myeloproliferative or lymphoproliferative. All these can have blood eosinophil count, which can be high. There is no specific cutoff for pediatrics. It is region-specific, country-specific. Adults usually have a cutoff of more than 300. Children anywhere between 150 to 300. But we have a peripheral eosinophilia count, more than 4% is what we usually take. It can decrease with steroid use, like we use in FeNO. Now, what is the role of BEC and FeNO in diagnosis? High BEC may support type 2 asthma. High FeNO may support type 2 asthma. Can help to phenotype asthma. Eosinophilic type 2 asthma is seen in high BEC and high FeNO. Treatment not practical for asthma. We can rely on FeNO and spirometry more to titrate drugs rather than BEC, because you cannot ask the child every time to have a blood test to see just the eosinophil count to see whether it's following. It is not practical to do in a setting. We might lose follow-up of this child because of the frequent blood pricks. So I would say for treatment, we should not practical follow-up. For prognostication, it can help to risk an exacerbation, but I would say utility of FeNO for an exacerbation, but more than I would say the utility of the inexpensive, invaluable peak expiratory flow meter to anticipate an exacerbation is much more than a FeNO. If you have facilities for FeNO, then why not? Please use FeNO. It has a high risk of exacerbation in an ICS treated patient. Now, what is this biomarkers of inflammation? The last scenario is also a first year postgraduate pediatric who is interested in pulmonology. He requests us for a thesis topic, asthma related, any investigations I can do. So what is this? So we have a lot of non-invasive investigations which we can do. What are these non-invasive and investigative investigations? Exhaled breath condensates is one. Induced sputum is the non-invasive investigation. I will come to this briefly over the next 1 to 2 minutes. So we don't do it routinely, definitely, unless we think of an alternate diagnosis, or in refractive resistant, therapy resistant asthma, TRAs, we are very theoretical. In a clinical practice, we don't do it. Lavage, biopsy, or an open lung biopsy is invariably never done in bronchial asthma. Non-invasive measures, what are these? So this is purely a research tool known as EBC, also known as exhaled breath condensates. We know palmistry, like we know we know what is there are astrologers who can predict things like molecular, with our handwriting, molecular signature. Just as we have in the MRA brain, the molecular signature, we can have lactate peak. So there is something known as biomarkers like exhaled volatile compounds. This is one component known as eNOS, electronic sensor, which measures these volatile compounds. It transmits to different signatures by pattern recognition, different compounds like nitric oxide or certain compounds, and it gives us a system output depending on what is high in the exhaled breath condensates. So this is purely research, theoretical, not practical, expensive, and to my knowledge, it's not practiced in any part of India except for very research centers in the United Kingdom or the United States of America. Going on to induced sputum. There is a famous paper in 2020. As of now, adult has a proven role. An induced sputum which shows eosinophils more than 2 to 4% may point towards a diagnosis of type 2. As of now, it's a research tool. I would say to conclude, induced sputum is only used in tuberculosis, not in asthma. We always induce with hypertonic saline. There might be a risk of bronchospasm in a child who already has a bronchospasm component. Analysis of sputum cells, mainly matrix, of the factors which we do here, but it is theoretical. And
clinical benefits are uncertain, impractical. Currently, GNS says only for adults, not for children. That is the take home on induced sputum for pediatric population. Now, what will be a takeaway and closing thoughts for from a general pediatric perspective? I would say this 9 to 10 points is very important from the current era. We always, it's time immemorial, we have been taught that we have to have a clinical pattern recognition. That goes without saying. We aim for subjectivity always, but current era, please aim for objective diagnosis. Once we do an objective diagnosis, please demonstrate variable expiratory flow limitation as indicated by a peak flow spirometer and prove a bronchodilator responsiveness. If we do an exercise challenge, if you have the facility, do an impulse oscillometry. Document response to ICS always to know that we are in the right track. Use impulse oscillometry when PFT is normal or in the preschool user who cannot do a pulmonary function test. Use blood eosinophils and FeNO if spirometry is not available or if normal. Not if invariably you may have FeNO, but blood eosinophils is cheaper. But if it is normal or if it is not available, you can use either of these. Phenotyping asthma is always crucial for follow-up and long-term classes. Not one size fits all. There is an old saying which goes to that goes good with asthma also. Prove atopic asthma with SPT or specific IG by immunocap method, and always have a modified asthma predictive index, which will comfort the parent, help us to know, and will run long-term management. We require more research for exhale breath condensates and induced sputum. I know many experienced teachers are within this valuable audience here. So one of the research topics to your thesis topics could be these. Clinical diagnosis plus a therapeutic trial. This is one thing. Therapeutic trial is you don't have facilities for anything. If you have no options, only you can consider this and see if there is a response, particularly in a preschooler. And if you see a good response, please continue inhale corticosteroids. But if you don't have a good response, please refer to a center where we have facilities to do these tests. Z-score is the current gold standard in spirometry evaluation. We have moved on from percentage predicted values. Z-score is like a universal measuring stick. It shows how far something is from the average. So thank you for all your patient listening, and I would like to take any questions which you all have.
Oh, thank you, Dr. Vivekanand, for that excellent talk. We have some questions in the chat box. Can you read it?
Sure, sir. Peak flow document, can you speak loud? Can we use PFR to diagnose exercise induced? So for the first question, I think we can use definitely. So we do just like we demonstrate a fall in FEC by 12%. We see if there is a 15% fall in 15 to 20% fall in peak flow after the exercise. Definitely we can do. Dr. Jitin's question was that. Dr. Jijo has asked the timing of FeNO is also a confounder. After definitely, I agree with that. So, but probably I would say little more theoretical. We can probably, if you want to be very much more practical, we can time and do our test, particularly on, we can have it as a technical visit. You come on this time, particularly for a FeNO testing, so that we avoid the confounders. We can ask them to come in the morning time first, as I can see. Dr. Vivekanand sir has asked FeNO cost, sir. Am I right in understanding that sir has asked about the cost of FeNO experimentation? FeNO, probably FeNO machine cost, it ranges between around anywhere between 4 to 6 lakhs, sir. Around 5 to 6 lakhs. Minimum 4 or maximum 6 lakhs. For a test, usually it costs around anywhere between 1.5 to 2,000, sir, for a single test. It is definitely costlier than a spirometry, sir. And sir, Dr. Jitin sir again has asked, does FeNO indicated in all cases of difficult to treat asthma or absolute QCP is enough to label as type 2 TH2 I think we use a combination, sir. Difficult to treat asthma, definitely please do a FeNO, sir, because we want to know. If the FeNO is still high, you will see whether it's really therapy resistant or triggers, adherence, compliance, environmental allergens, all these things will become. So definitely, I would say if you have FeNO, eosinophil count both together, use both. If you have only one, FeNO is costlier. If you don't have anything, please use eosinophil count alone. But if you ask which is better, I would say FeNO is better. 300 for AEC, isn't it too low? You're right, sir. And 300 is for cutoff, particularly in our population, but there is no specific reference for pediatric. Usually anything 4% is what we take, sir. 4% of the peripheral eosinophils is more than an absolute values usually. Dr. Padmapriya Madam has asked, so madam was regarding the presentation, and Dr. Sanjay, 4% or over 6% is considered as significant in asthma or allergy. Sir, I'm not able to, sir has asked whether is it reversibility, sir is asking, or can I understand your question more specifically, sir? I'm not able to follow the question actually.
Vivek, I think it's about eosinophil count.
Is 4%, sir. The peripheral eosinophil count is 4%. Why neonates have high eosinophil count? Does it have predictive value in future asthma in first degree relative? Very interesting and important question. Practically, I would say I'm unaware that neonates have high eosinophil counts. It's actually new to me. Probably I would look into this question and through Dr. Jijo, I will ask this question. I am not sure. I have not read any studies personally, and this is actually new to me. I would definitely take this question into consideration, and through Jijo, I will get back to you, Dr. Sanjay. When food allergy test is indicated, most of the time, wrongly attributed. I completely agree with you, sir. Dr. Jijo would also agree with me, or Jijo would, if any points to differ, Dr. Jijo can, we can coordinate here. So when food allergy, I know it is increasing, but I would say it is less than 3 to 4% in an Indian population. But when some allergy as documented from a history or any of those tests which we discussed, the risk of asthma is definitely more than double. So food allergy does exist, but invariably many of the times parents attribute it to each and every food. But if there is strong proven food allergy, it triples the risk of asthma definitely.
Can I just add one thing, Vivek? So one of the biggest problem which we face is many times parents undergo the allergy testing even without a doctor's prescription also, and they consider that, but they avoid a particular food. And we have many practitioners who say you are allergic to so many food, so don't give these food items because your allergy test is positive. That is one concern which Bindu has been raising. So blanketly, especially during the growing period, all of them are asked not to take the food based on the test. And also many a times there are many practices wherein they will say, do not give banana, do not give curd, do not give citrus fruits. All these things can trigger asthma. So these are the concerns which are there.
Definitely, completely can't agree more with Dr. Jijo, what Jijo has said. So I think it is very prudent to. I think time is what is very important. We need to see what is relevant, whether the test, whatever test was done, was it appropriate, and whether it is the sensitization, whatever has been proven, does it equate to allergy, and then can take a decision on whether they are going to avoid that food or not.
Just one point where, so what is the new gene, one of the things which they have told us regarding eosinophil count, even though they say 4%, what they have asked us to look into is the population norms. So if you are living in a population where on an average your eosinophil count is 4%, I would say you should take at least 8% as to be more significant, because if you have a high helminthiasis, you have other reasons wherein the population eosinophil count itself is on the higher side, you might have to use a much more higher cutoff of eosinophil count when you're considering to be part of asthma per se.
Yes, like very rightly said, particularly in a tropical place like us with parasitic infestations, it is definitely prudent. I would just ask from the audience, I would like to know, or from Jijo itself, do you do frequently? I have never done it actually, unless for its refractory case, not to as an initial diagnosis. How frequently do you do, or any of the pediatricians do? Can I know from your practice, like Jijo, do you do it in practice, peripheral eosinophil account?
No, we don't do eosinophil count. What usually happens is many times they will have some CBCs with them, which they would have done for multiple reasons. So when the eosinophil count is high over there, it is an indirect indication telling us this is mostly an eosinophilic asthma, which is why the eosinophil counts are there. But as a routine for all patients of asthma doing a CBC, I wouldn't suggest. But then they will have one or the other CBC which have been done for some exacerbation.
Definitely, particularly when you have referrals. I would say like almost 50 to 60% of them invariably would have a peripheral with a CBC and also a total AG.
One more question is there.
Yes, sir. Which one, sir?
Does FeNO indicated in all cases of difficult to treat asthma?
FeNO, yeah, definitely, sir. I would say if we have a spirometry FeNO, definitely, sir. It helps us to, definitely, I would say in all cases of difficult asthma, please go ahead to do a FeNO. I will definitely attribute value to it.
Any other questions? Participants can unmute and ask. Okay. So thank you, Dr. Vivekanand, for that excellent talk. Actually, as Gobi said, we usually hear about acute asthma management, the severe acute asthma diagnosis. One problem with the practicing pediatricians is that confusing terms used by GINA. Most of the time they change it also.
Yes,
it's
sir.
very difficult for, maybe it's easy for pediatric pulmonologists, not easy for practicing pediatricians like us. So thank you, Dr. Vivekanand, for that excellent talk. Hearing first time such a talk about diagnostics in asthma. So thanks. Thanks to all the participants who attended this meeting. Thanks, Jijo, Riya sir, Gobi, Nandukumar, and all the leaders. Thank you.
Thank you, sir.
Thank you, everyone.
Thank you so much for the opportunity.
Thank you, Vivek. So Vivek is one of the people whom we can strongly recommend to refer patients if somebody asks you who to send for a pulmonologist in Chennai.
Oh. And one suggestion to Dr. Vivekanand, actually, to make that PowerPoint font slightly bigger, because most of us see in mobile.
Oh, okay, mobile, sure, definitely.
Sure, that's a small font. It's very difficult to read it. Thank you.
Definitely. Sure.
Otherwise, excellent talk, sir. Excellent talk. Thank you for that.
Thank you so much.
Thank you, Vivek. We'll share the YouTube video also.
Thank you. Sure.
Oh, thank you.
Thank you, Jijo.
Thank you.
Sir.
Good night.
Good night.
Good night.
Good night.